Yeah, so thank you very much for having me. I'm going to kind of give you a whistle-stop tour of some research work I've been doing for the last 3 years, but also talk a bit more generally about NIHR clinical academic career pathways, because I think this is information that can be quite hard to come by, and hopefully it'll be helpful to some people in the audience. I'm going to try and keep this series obviously open to all healthcare scientists. I'm going to try and keep this fairly general and hopefully more applicable and understandable beyond medical physics. But I'm aware there are quite a lot of physicists in the audience. So if you have questions, I'm very happy to answer them at the end. So for those who maybe aren't familiar with PET-CT imaging, it's a functional form of imaging that is primarily used in oncology pathways. So we inject patients with a radioactive tracer that's attached to a glucose analog, and that glucose is taken up in tissues in the body that are metabolizing quickly, and that's often cancers. And it produces two different types of images. We have our PET image, which is a map of this metabolism in the body. So the regions of dark are where there's lots of this tracer. So here we can see that there's some in this region here, which is outlined in pink, which is actually a tumour. And then we can also see some here, that's the kidneys and the bladder, and that's actually some of the radiation that's being cleared through the body because it wasn't taken up in the tissues. And then we can also see other things. So we can see this kind of fairly uniform grey region is the liver. But we also take a CT image, and this is a map of the anatomy in the body, so that we can see better where the different organs are, and the doctors use this both to interpret the image, and we can also use it to improve the quality of the PET image through a number of different processes. We can fuse those images together so that we can look at them both at the same time. And that's what this looks like on the right here. Sorry, I just realised I haven't got the pointer on. Over here. And these are used very commonly in oncology pathways because they're very, very sensitive to small regions of disease. So this is actually quite a large tumour, but it can show up where there might be cancer spread. And it's also used for various other purposes. The scanners look a bit like this. Physicists are very involved in this pathway in terms of calibrating the scanner and checking the scanners are working properly, and then also optimizing the images to make sure that the images we're using are the best that they can be for the patients and for the doctors who are reading them. My doctorate's actually interested in kind of going beyond this and how we can analyze the images to get more information out of them. And this is referred to in my talk as radiomics. So in the context of oncology, actually, the only information that looks at a whole tumour that we record is the 3D whole body imaging data. And it's been shown quite a lot in literature that when we combine that with other omic data, so things like genomics or pathology, it can provide really powerful insights into how a patient's cancer is progressing, maybe how it's responding to treatment, or what their prognosis might be. Now, this is particularly relevant in PET-CT because it's a functional imaging modality. So the image is telling us something about how the tissue is functioning that we're looking at in the image. But commonly, that quantitative analysis, like the numbers that we're extracting from the image, is very limited. We pretty much only extract the maximum signal, and we use that as a measurement of the maximum metabolism in the region, essentially. But there's a lot more that we could extract from these images. So again, for those in the audience who maybe aren't so familiar with medical images, images are really just a big table of numbers. Like if you really wanted to, you could make them into a kind of Excel spreadsheet format. There's just lots and lots of numbers in each different pixel in the image. And from these, we can extract different things. So we could extract something like the maximum signal. So the regions of dark in this image are where the signal is higher. But we could also extract other things from this image that maybe might characterize the tumor better. And this is important because actually lots of very, very different tumors, see here my very physics example of tumors, can have exactly the same maximum signal. So if you were to look at these kind of as a computer, if you're looking at 5 different images, they're very, very different, but actually they have the same maximum signal. So if we wanted to better characterize them, we need to use more complex kind of quantitative measurements to understand what these images are actually showing about the metabolism in the tumor. And particularly relevant, like how that metabolism is varying throughout the tumor. And so we can start to add in different features. Now, the exact features I'm talking about here are matrix features. So essentially they analyze the texture. Exactly what they are is not hugely important, but what is important is that we want to kind of better be able to differentiate between these 5 images. And we can see that as we add in more different measurements of this image texture, so this one counts consecutive voxel runs, so you can see that you'd get a longer run across this image here than you would in this one, because there's like dark and then light in small patches. And, we can start to differentiate between these images quite quickly, actually, across a fairly small number of features. And that's what radiomics is. It's essentially extracting these quantitative measurements from images that can help us differentiate beyond just a single metric. Now, obviously, we can't then, you'd need as many features as there are voxels in the image if you wanted to do that backwards and perfectly characterize each image. But it's, can we better group and stratify the images to kind of understand how they're behaving? Radiomics is quite a rapidly growing field. There's been a huge number of publications on it in the last couple of decades that show that if you extract these features, you can then correlate them with patient outcomes, and they are showing something that's biologically informative. And so there's quite a lot of potential for kind of standard of care imaging data to provide unique insights into diseases in this field. So in this image on the right here, it's a kind of fairly standard radiomics pathway. So you have the data collection at the examination, different types of imaging. You then have to segment your tumour volume, you extract the features, and then you can analyse the data, and perhaps like this diagram here is kind of showing maybe differentiating two different groups of patients. And then from there build some kind of predictive model that can tell you whether those features that you've extracted are clinically informative. In the context of my doctorate, I've been able to look at retrospective data I look at sarcoma, which is quite a rare type of cancer, and in Oxford we're a quaternary service for this, so we have quite a wide population who come to us for their care. And through one of the secure data environments, which is a term I think you'll probably be hearing more and more in the next few years, we've been able to access both the imaging data and outcome data for this. So in the context of as a clinical scientist, though, one of the things I was really interested in when we started this are what are the challenges? This research has been going on for years and years and years. We know that this potentially has quite a lot of application. It's, showing us more than just the kind of maximum signal in the image. But actually, none of this is really coming into clinic, and why might that be? So as much as, we've got our 4 images here now with different images that have the same SUVMAX, actually we can do the opposite, and we can take exactly the same underlying image data. So this is a kind of specialist phantom we have in Oxford, and reconstruct it in different ways, which just means how we generate the image from the data we've collected, and we can get a different signal depending on how we reconstruct it. And so this is a huge reproducibility issue. We can't then take models that were trained in one centre and use them in another centre because of the differences in the way the models behave. And this is particularly relevant to us, I think, as clinical scientists, because we're often responsible for how we can implement these algorithms or check that they're working in our data. And so being able to understand how they behave is really important. So this is just another example of this. In Oxford, we commonly use the GE acute clear reconstruction. It's a Bayesian block sequential regularization expectation algorithm. So the primary parameter that you can change in the image reconstruction is beta. And you can see here, this is exactly the same underlying data, how much I can make these different images look very, very different depending on how I change that imaging parameter. This is very, very extreme. Clinically, we use the 400 right in the middle, and we definitely wouldn't be using a 1 or 7,500, but it does show you how much I can change that imaging data with just a single parameter in the reconstruction. And also fairly obviously, if we're then going to extract our quantitative measurements from these images, you can see how much those radiomic features would be dependent on those image noise characteristics. Now, radiomics actually, therefore, can probably also help us better characterize the image. So if we can see these differences, can we also use it to help us understand how images are behaving? And we thought this might be particularly useful in the era where we're looking at kind of AI and deep learning image enhancement in clinic. And so that's what kind of some of the work we did looked at. So we looked at 2 different deep learning image enhancement algorithms that we had research access to. And essentially they take kind of low computational input reconstructions, and then they've been trained to reproduce a kind of high computational output reconstruction. So from kind of essentially a relatively cheap reconstruction to a more computationally intensive output, with the aim that essentially you can then do that without having to, do this is a computationally cheaper route to this better quality image. But we wanted to understand at the quantitative level, how are these images behaving? And we thought that with radiomics, we might be able to do this kind of beyond, again, just SUVMAX. Can we consider this more in the round in terms of the image texture? We were able to do this, so essentially across the features, we compared the input versus the output, and then the enhanced image versus the gold standard. And essentially, this is the proportion of significantly different features. So if you compare the input and the deep learning enhanced image, you've still got a fairly high proportion of the radiomic features that are different, which is as we expect because we've changed the image fundamentally. So we would hope that it would change. But if we then look at the enhanced versus the gold standard, it was trained to replicate. Actually, there was only one feature for one of the different phantom measurements that was different. So it was this was a very pleasing result. And essentially, I think it was a really neat example of how we might be able to use things like this actually in kind of a robustness testing environment, as well as for like prognostic capability. We published this, it's a shameless plug, in EJN MMI. I put this in as well because I haven't really been able to go much into the technicalities of this. It's a 20-minute talk, so if anyone's more interested in this, you can find it here. And then something else we've been looking at is automated quality control. If we want to look at kind of large-scale retrospective data, then we're not probably going to be able to look at eyes on every single case. So can we use AI technology to help us understand which of these images might have errors in? Because it's very plausible that there are some images in these data sets that have errors in. So we kind of started this by thinking about the guidelines in PET, which recommend looking at a region in the liver, and also checking the alignment. We've primarily focused on this liver measurement at the time being. And this is plausible now because there are automated organ segmentation approaches out there that are very easy to use, and it's very very like resource cheap. It doesn't take you time anymore outlining these organs, which can take a huge amount of time. You can apply these, leave it for a few days and come back and that's been done for you, and they're very highly accurate. So actually my doctorate work looks at sarcoma, in which you can have very, very large abdominal tumours. And I was very surprised at how well these segmentation approaches worked, even in patient cases where the tumours significantly distorted the position and the location of the organs. And so we wanted to look at the ability to use liver uptake automatically to quality control clinical images. This was in the retrospective context at the moment, but we are maybe looking at moving it more towards automatically doing this in real time in the future. And actually we've had quite a high degree of success with this. So the guidelines recommend, the reason this is interesting is the guidelines recommend using a sphere in the upper right lobe of the liver, and you need to place it specifically in a region without disease. But actually we were able to show if you use the whole liver region, then actually even there's only a very small minority of cases whereby sufficient disease is included within the whole liver that it significantly changes the SUV mean. And so actually we replicated the result from literature. It's more significantly different in SUVMAX, as you would expect, because MAX is dependent on one single voxel and will be significantly affected by patients with liver disease. But this is a fairly neat result. And so, sorry, that's a bit of an abrupt ending actually, but essentially we've been able to look at lots of different parts of reproducibility and robustness in sarcoma, but also more generally in FDG PET. I'm going to talk a little bit about NIHR clinical academic pathways. This image is a terrible resolution. I couldn't find it better anywhere, but I think it's quite a good summary of the different things that are accessible. I should also say at the start of this, there are other funding bodies that offer clinical academic pathways, and increasingly those funding bodies are also opening them up to non-medics. Historically, NIHR were the first to open up these funding streams to non-medics. So I'm going to focus on that because I've done my doctorate funded by NIHR, but there are other options out there, particularly from the MRC and some of the big UK health charities as well. So NIHR have this kind of pathway of clinical academic careers, starting with the pre-doctoral routes all the way up to professorships and chair positions. I've been doing a doctoral fellowship, and I was fortunate to have some, at the time it was called Health Education England funding, which was quite similar to a doctoral fellowship, which gave me some protected time to prepare a doctoral fellowship application. And then there are advanced fellowships and development and skills enhancement awards. I'm afraid I can't really talk so much about this bit. Obviously don't have experience of it. I'm not there yet, but I'm going to give you a little bit of a background to pre-doc and doctoral fellowships, and hopefully some pointers if this is something you're interested in. This website has all the information you might need about the different funding opportunities that there are available. So pre-doctoral fellowships are essentially designed to pay for some of your time to prepare to kind of start your clinical academic journey. With a view, if you're thinking of applying for a doctoral fellowship, it can buy out some time to help you kind of prepare that application. They're mostly targeted more though at researchers who don't yet have a master's, so they can fund your master's or some courses that you think you need to do to be able to prepare like a competitive doctoral fellowship application. So I didn't do a pre-doc award because I, as part of the SDP, I already had a master's. I felt like I was very well supported in Oxford, and I didn't feel necessarily needed that protected time to prepare an application in the same way. I did have some funding from Health Education England, as I previously mentioned, but these can be really good if you think that you need that time or there's a course you want to go on before you apply for doctoral fellowship. So have a look at those. And then the doctoral award is 3 years of fully funded, fully salaried at your current NHS band, protected time to undertake a PhD by research. So these have slightly changed since I applied. There used to be 2 different schemes called the Doctoral Clinical Academic Fellowship and the Doctoral Fellowship. They are now merged. So it's all under one body, whether you're a medic, dentist, any kind of healthcare professional or like a social worker, they are all funded through the same scheme. And it opens twice a year in April and October. My key piece of advice, if you are thinking of doing this, is don't underestimate how long it takes to put together a doctoral fellowship application. And they're a really sizable piece of work in and of themselves. So yeah, definitely like factor in quite a lot of time, and particularly right at the end, factor in a lot of time for doing all the sign-offs. There are a lot of people that you will need to get sign-off from to apply for one of these. And obviously you need to have buy-in from your supervisors and your line manager early on. But even right at the end, you'll definitely need a lot of time just to get all the signatures on the application, which I think if you're applying for a doctoral fellowship, you've probably not done a grant application before and you might not be aware of. Historically, healthcare scientists have been really underrepresented in NIHR career development fellowships. So I think that's starting to change. I think there's lots more people out there now applying, but you're really well placed as a healthcare scientist to be applying for these awards because you're a scientist. You have that kind of scientific inclination to ask questions, find out the answers. So definitely like have a look into it if you're interested in research or interested in clinical academic careers. And again, if you're interested in applying to NIHR, any kind of NIHR grant, or in particularly including the academic pathways, find your local research support service and contact them. They're incredibly helpful at all stages of the application. They can help you with like proofreading your application, critiquing it. They gave me a mock interview that was much harder than my actual interview. And they can also help you with things like patient and public involvement if you contact them early enough. So they're really helpful when you're coming to like putting together one of these applications. They also gave me probably the best advice I had applying the whole time, and is that if you're looking at a career development fellowship, and particularly the doctoral fellowships, they're thinking about 3 things when they assess your application, which is person, place, and project. And those are in equal weighting. So like, are you the right person for them to fund? They're looking to develop you as a person as much as they are looking at the output of your research. So they want to know that they're investing in the right person. Is the place right? Or have you got the right supervisors? Have you found a supportive research group and a supportive university? And then finally, is the project right? Like it has to fit with the NIHR remit, which you can read more about online, but it also has it got patients at its centre, but it's not the most important part of like a clinical academic application. The most important parts really are you, and is the project going to kind of help you develop your skills? A massive thank you to the 2 research groups that I'm a part of in Oxford, the Hassan group and Dan McGowan's group. I'm very lucky to be involved with both of them, and also a huge thank you to the clinical department in Oxford. I wasn't there the day they took their group photo, so I haven't put it on the slide, but they've been really supportive the whole way through applying for all these different things.